Hello, everyone, and thank you for joining us today for another Pilot Grant program seminar. My name is Danielle Kenyon. I'm Program Director of CRCAIH, and so excited to start this series up again this second year, and we are back in Sioux Falls with Dr. Marylou Mylant. Dr. Mylant is a professor in the College of Nursing in South Dakota State University. She's a family psychiatric mental health nurse who's currently involved in the assessment of adult attachment patterns using pictures and storytelling. Dr. Mylant has served as an evaluator and intervention specialist in several of the Northern Plains American Indian Youth projects, which have focused on high-risk youth and teen parents. She has published her findings and articles on these topics, as well as in alcoholism and its effects on children and adolescents and supportive school-based interventions. Dr. Mylant teaches mental health nursing, health promotion, and research. She's certified as a trauma specialist and completed a certificate program in human-animal interaction and health and equine-assisted therapy and learning. She has practiced as a pediatric nurse practitioner and more currently as a family psychiatric mental health nurse practitioner, which has allowed her experience the protective effects of attachment upon health across the lifespan. Dr. Mylant considers it an honor to continue to learn from the American Indian families she's been privileged to work with. So please join me in welcoming Dr. Marylou Mylant.
Thank you very much, Dr. Kenyon. Yeah, I knew I was home when I pulled in and saw all the horses out in the field. I said, okay, I have to go into the building and not be out here and get my fix. But I wanted to first recognize Dr. Mary Isaacson as well as Jennifer Heil, who, without their collaboration, couldn't have accomplished this pilot program. I also wanted to acknowledge and thank the Collaborative Research Center for American Indian Health, or CRCAIH, and Dr. Amy Elliott, whose grant through the NIH, National Institute of Minority Health and Health Disparities, helped fund this grant. And it was a pilot study to look at the relationship between caregiving and health, primarily heightened weight of young children, focusing on preschool and kindergarten age children. At the time of the study, 38% of the children, kindergarten children and preschool combined at the rural reservational school that we conducted this project, were either overweight or obese. We know that children who are overweight when they start school are more likely to be overweight as teens, and half of childhood obesity occurs among kids who are overweight during their preschool years. I mean, even birth weight has been possibly associated with obesity risk. Current evidence also shows that overweight and obesity are associated with adversity and social stressors. American Indian young families are more likely than non-Native families to be headed by younger first-time caregivers with fewer resources and greater likelihood of adversity, such as trauma and loss. Yet no research had been identified that looked at the quality of caregiving among American Indian families as a protective factor against obesity. And furthermore, the rural reservational school that we worked with was concerned about the low caregiving participation with the school and wanted to engage the families, especially the young parents in the community. And so the objectives of presentation today is for you, and I'm sure you understand already, it's like preaching to the choir, the importance of cultural competence of interventions with specific American Indian populations, as well as the importance of co-creating those proposed interventions with community stakeholders. Just as a background, as I mentioned, American Indian young families are more likely in need of preventative health interventions that strengthen that protective role as caregivers because of what I mentioned before. They're more likely to be headed by younger caregivers that have fewer resources and more likely being exposed to adversity. And the rural reservation school we partner with, besides asking us to help engage their younger families with young children, primarily the preschoolers and their caregivers, the main reason for that was that they had taken over the preschool in the community. There was no longer a Head Start in the community. And so probably the preschool was up and going about just 3 years and not much connection with the community involvement. We also know too that attachment and childhood adverse events have as much importance as genetic factors in either the prevention or the development of a lot of social, emotional, and physical morbidities such as depression, substance abuse, and diabetes, which again are pervasive health problems in the communities that we work with. Our long-term goal, too, is to promote strong families and American Indian families and improve child health. So we decided to focus both on caregiving and obesity, knowing that that was an issue with the young preschoolers and kindergartners. It's a fairly 2011 study by Hearst that identified that 46% of American Indian and Alaska Native children were overweight or obese in South Dakota, and that coincided with what we were finding. In fact, at the year before the study began, 60% of the BMIs of the 25 preschoolers and kindergartners in our study were greater than the 85th percentile before we began. And so the purpose of our study was to really follow the national goals for health promotion and disease prevention, which suggests that there is an urgent need to develop strategies to address social determinants of early risk factors such as obesity and chronic illness. Our purpose of this study was to examine the efficacy of an evidence-based parenting program called the Strengthening Family Program and the protective effects of caregiving. The Strengthening Family Program had shown to positively affect caregiving as well as physical activity and nutritional knowledge. So our central hypothesis was that, since we expanded the age group, we went ahead and reached out to kindergartners as well. Since overweight, what we looked at was, knew that overweight 5-year-olds were 4 times more likely to be obese by age 14. And that was a 2014 study by Cunningham that, again, they were not all American Indian. And so the age group of the children that we worked with really ranged from anywhere from 39 to 80 months of age. And since we wanted to look at the quality of caregiving among American families as a protective factor against obesity, we identified a parenting program that had successfully been adapted to other American Indian communities, and it was a Strengthening Family Program for 3 to 5-year-olds that also included a nutritional and exercise module. However, when we received the training, we really saw that it really needed to be adapted and spent a lot of time, especially with the first wave, adapting the program to really meet the needs of the culture we were working with. We also needed to fully incorporate the exercise and nutrition program, again, being culturally appropriate to the community we were working with. And so we used the Eagle books and the Health is Life in Balance, which I will talk a little bit more about. I'm going to first talk about the parenting interventions that were adapted, and then speak about how this was done with the children's group. We provided 2 14-week sessions of the Strengthening Family program. The initial group in the fall was with the preschoolers, and then in the spring was with the kindergartners. And as you can see from the slides, like I mentioned, we incorporated the Eagle books and Health is Life in Balance. For the parenting group, I really relied on the elder caregivers, often grandparents in the community raising their grandchildren, to really guide the parent content in a culturally sensitive way. The elders, as you can see here, were definitely so important to the younger children that they were great role models not only for the younger parents, but also partner with many of the children whose parents or grandparents did not attend the group. This is an example of a family session, and both a combined family session, a children's group, and a parents group occurred every week. Probably ranged any time from noon to 3 o'clock in the afternoon. And this is an example of when they both came together. Let's say the parents were separated, then also the children had their own group. This was when they both came together, and they were able to apply with both the caregivers could apply what they learned in their group, and the children as well in their group. And this family group from the first session really introduced the children to the Eagle books. And then also with the parents, we talked about communicating in a positive way and spending time with their children, again, in a positive way that gave the children some independent or one-to-one attention. The children in the children's group, the group leader read the children's group. There were these huge, large copies, like 3 by 5 copies of the books that the teacher read to them. And then the parents were given a copy, smaller copy of the book to then read to their children. And then at this time, another practice skill that the parents had learned was, like I said, giving that individual positive regard to their children. And so this was part of the children's game, where the children were able to pick any kind of picture from each one of the books, which was actually a coloring book. And this is called the child game, where, again, the child is in charge of the activity you see here, and the parent's role is just to observe, comment to the unique factors of that children's coloring and drawing. Usually the family session too included a physical activity, and the Eagle books do emphasize that. What you see here is a caregiving pledge card that the parents had to complete during the first family session. It was a pledge to engage at least into one family activity that week. And during the family group, we actually had one of the preschoolers and one of the school staff who actually organized the dance group and hand games for the school to come in and demonstrate both to the parents and the preschoolers, and to teach them the round dance. And those activities were really important, not only for the children, but also for the young parents to then really allow the elders to educate them about their culture. There was always something that the elders spoke to me about that they just don't listen. They don't want to listen. And this was one time that they had to listen and to at least watch the elders demonstrate. And in this situation, the staff member, the children also then had great fun in recognizing some of their body cues or hints that their body was active or had been active. We had them notice that their body was sweating, or their cheeks were red, their skin was warm, or their heart was beating hard, and they were breathing faster. And what we had found is that these Eagle books have been distributed well across Indian country, but oftentimes, perhaps the books were just given to the children or maybe to the teacher. And so this was a resource that we really were excited about. And, you saw that, the eagle is taught to be a messenger or teacher and represents balance, vision, courage, strength, and wisdom. And so again, was really excited about it. And the kids, we oftentimes used the puppets to tell the stories. I first brought an eagle in that was one of the birds that can actually make the eagle sound, and the preschool teacher quickly put that away. But I left the website of the Eagle Book resources. Besides the videos, there's also animated versions where children can get, parents can get the Eagle Book in disc. There's games and activities, and you could see too that there's a guide there for educators to the left, and that's available to really see how to incorporate the lessons from the Eagle books. We also not only used the puppets to tell the story, but throughout the group and through the children's group also used puppets for the kids to express their feelings. Oftentimes, either that was not an okay thing to do, or they themselves were just preschoolers and learning how to express their feelings verbally instead of physically. And so in a lot of ways, they just really enjoyed that, especially if they were talking about something that was difficult to communicate about. Not only the Eagle books, but we also use the diabetes education in tribal schools, Health is Life and Balance curriculum. And this too, here it says K through 2, but the very beginning, there is a short preschool piece. So there wasn't, either we had to adapt some of the older activities to the younger age group in a unique way. Then, and also again, but it did give a cultural way to really incorporate not only education, but prevention, lifestyle components that promote diabetes prevention. And the curriculum has been shown to delay type 2 diabetes by over 50%. Although, and like I mentioned, this module goes up to the 2nd grade, but there's modules for upper grades as well. My Native Plate was another tool from the diabetes prevention education from Indian Health Services that was used. We started each week with a family meal, and it gave children as well as parents, as well as myself, a great resource to look at what is, correct portion sizes. And that's adapted to My Native Plate, made it even, much more relevant for the group. And there's a lot of resources too that we had found on that site. The Qualitative first of all, the quantitative findings. We used a somewhat mixed method where some was quantitative, but very minimally here we had just looked at child BMI, pre and post. I think one of the things is important to know that's not a strong measurement to use, especially knowing that, you know, there was only 16 weeks from pre to post intervention in each age group. But, and knowing that, like I mentioned, in both treatment group and the waitlist control group were 25 children. So we really just looked at percents of what happened to their, and we also limited to obesity rates, and found that at least the obesity rates in the two treatment groups, the preschooler group stayed at 14% pre and post, and the kindergarten group, or wave 2, stayed the same at 38% pre and post. And we looked at the waitlist control group, which was the kindergartners during the fall semester when we were working with the preschoolers, and they increased from 30 to 50% without intervention. So that was one of our, key findings quantitatively. Citrix receiver.
Yes.
Okay.
Okay.
All right. Probably the richest was the qualitative results we received, and this was gathered through a focus group that was led by Dr. Mary Isaacson, the co-investigator of the study. And the focus group included three parents, 2 fathers, 1 mother, and 2 grandmothers. And some of the questions that we asked them were, while, the Strengthening Family Program was in session, could you tell me if you noticed any changes in your child or children's behavior? What ideas do you have to gain more community input and ownership for the program? Or how could we serve the other families better that didn't participate, and if they had recommendations, and how it could be integrated into the curriculum? One thing is that it was integrated into the preschool teachers' curriculum. I first have to say that this picture was taken by Dr. Isaacson, as I mentioned, who did the focus groups, but it's a great eagle picture. So thank you, Dr. Isaacson. And when we started to analyze the focus group narratives, we found 3 overarching themes: the positive child behaviors, the meaning to the child, and then the adult disconnect. And then under positive child behaviors, there were 3 sub-themes, like improved caregiver to child and child-to-child interactions, knowledge of healthy eating, and the increased use of traditional language, which again was brought about a lot from the elders in the group, and giving the children names for different colors. Also, they're, in the parenting group, I'm talking about different activities that are culturally appropriate. And some of the examples of the positive child behaviors were given by Father 2, who had 2 children, one in the kindergarten group and one in the preschool group. And one in the preschool group, he said he just likes to sit there and listen. Like they'll help each other out like that. Another example was given by grandmother 2. Well, words she doesn't know, she asked me. I lay there and listen to her and help her out. and that she reads. She just, at night she reads, she takes books back, and she reads. And healthy eating and language. The one mother stated that now with food stamps, eating healthy and stuff, I don't like going grocery shopping with him. He tries to break my bad habits. Says things like, if I try to buy candy or chips, he says, it's not healthy, Mom. Yeah. So Father, too, also mentioned that his daughter was 3 years old, and so not in preschool, but her siblings were in either preschool or kindergarten, so somehow made her way to the classroom because she wanted to go to class, and she was one that's, ready for high school already. And one thing the father, too, said was she was learning from her brothers and others as she sat in class and stated, I noticed my daughter counts to 5, and that was just amazing to him. The meaning to the child, Father 1, and this was with his kindergarten child, is that she always lets me know, remember, Dad, we have to go to my class, or you have to go to my class. Then adds, she's like, you miss out. You missed out. I'm like, I know, but I couldn't get away. She enjoys the stories and coloring activities they do. She looks forward to it. The grandmother stated, yeah, they're going to make sure you're there. I had some of the little ones even say, my mama couldn't come, and the children were upset. There was really an adult disconnect was another thing that was very evident. When we asked about how to get more parents involved, the participants didn't really have any idea or for improvement. They felt that it was generally just a lack of interest on the parts of the parents and guardians. And so lessons learned, that was a big lesson, that our future efforts have to initiate a similar program in reservational communities must begin with the community-based dialogue. We had that dialogue with the school and maybe a few community members, but not the community. Not the community, especially the parents of the children that were in the going to be in the preschool program or kindergarten, which was extremely important. And programs such as the Strengthening Family program that we used really requires a pre-training of the facilitators, and that in itself, is a barrier. As well as we made the American Indian adaptation, but that again needs to include the caregivers and members of the community. And also, if those parents whose children had gone through the program, if they could be key stakeholders and actually help facilitate future groups. Most of the facilitators that we used were trained school staff, and ideally we're thinking possibly an after-school program, yet these children, preschoolers, were way too young, possibly traveling an hour and a half to 2 hours on a bus one way. So that, and then too, then the school wasn't willing to release school time for the staff to facilitate a group. They did agree, and the preschool teacher did incorporated this into her curriculum just beautifully. And she was one of those that were trained. There was one person, too, an elder from the community that was trained. But for sustainability, really important to look at, possibly a program, and there is a Strengthening Family program that is shorter in length, that also includes online training that one could facilitate with the community. And because many of the individuals didn't have their own computers, and so I'm sure the school would have facilitated that. As far as recommendations for future study, would be to look at the relationship of obesity and health. It's been shown to be related as far as 6 days, visits to a physician, parent-rated children's health-related quality of life. All those have been shown in non-Native communities to be related to obesity, and to, again, look at that with a Native community. Intervention studies as far as shared meals. We know that, in fact, the one study had found that families who share meals that last at least 20 minutes, not more or less, and they have this down to a science, for a minimum of 4 times a week, weighed significantly less than their peers whose family meals were shorter. Now, this is in what American Indian families, in the studies that I've seen that have looked at, that being a risk factor for obesity, have found just the reverse, that it was more likely that Native children had more family meals together. I couldn't really say that for this community, although coming together as a family for those 16 weeks was really important. Also, too, that really looking at the effects of a trauma-informed parenting program. Interventions that, really take into account the needs of the caregivers. Many of the elders were children from boarding schools, were, just looking at the effects of generational trauma and also historical trauma, and to address their needs before then addressing their children. Why is it that some of the parenting did not get transferred over to the younger age group? Why don't they listen? But some of the more recent study that had looked at risk factors, like I mentioned, for overweight and obesity, still found that greater than 2 hours of TV time is a risk factor, and lack of neighborhood support and demographic characteristic, especially the lack of team participation, really significantly was associated with overweight, obesity among American Indian and Alaska Native children. And this was a 2012 study that was done, one in South Dakota, North Dakota, different states, I think Arizona, what was involved with that. And so it was especially that team participation, but one would have to think about all the barriers. Like I mentioned, many of the children were traveling from far distances, from other communities on the reservation, and so that would have to be really resolved, except they do their best to transfer the children, but then looking at the neighborhood support, getting the families to really be supportive of that, of the parenting program would be extremely important, for an example. And so I didn't know, I was going to open it up to questions.